Assalamu alaikum. Welcome everyone on board. Um, I'm just conducting this session after a long time actually, uh, and the purpose is to just make you all of you uh, at whatever stage of your career, or just to give you something which can make you utilize your time during training or training someone or after passing your exam in slightly better way. Okay. So, first of all, if some of you are, or like, if I can get any volunteer who is already in the training program. Pardeep, are you from Hyderabad? Are you the one?
Yes, sir.
Okay. Okay. So, okay. So, actually, and in any training program, uh, the thing which you should be knowing is that training is bilateral. Not like you can learn alone without your supervisor, and even your supervisor cannot teach you if you are not interested or you are not giving your input. Cause in our part of world where we don't have the facilities, where we are having an ideal environment for teaching, an ideal environment for training, you have to extract the things out of whatever opportunities you have. So for that, you need to be proactive, because if you will not help yourself, nobody will be able to help you. Okay. So this is the prime thing, whatever situation you are in, whatever, like, there are so many issues in our system, but you have to, even you have to try to, to get the best out of that time. Okay. So for that, like if you give an example that, of course, we all
Okay.
anesthetists.
Technical right.
Can you please mute your mic? Okay. So actually, like, for example, if I give you an example, that Pardeep, what case did you do today? If you can just tell me any case which you did, and we can just start from there. Or any resident who want to share the case, any case, just let me know, and I will start from there.
Sir, polypectomy.
Polypectomy, nasal polypectomy,
No, sir. Gynecological procedure. Polypectomy.
gynecological. Okay, I will just modify this case, because that will not be covering the thing which I'm trying to say. If I'm just telling you a scenario, you have a patient with hypertension, controlled, okay, and this is a real-time diabetic, controlled, around 50 years age, okay, good physical activity, now presented for laparoscopic cholecystectomy, okay. So when you have this data, what my first thing will be that, like, in this scenario, what are you expecting? Like, what, how you should be approaching this scenario? A hypertensive patient, diabetic patient with good physical activity coming for laparoscopic cholecystectomy at age of 50 years. Okay. Yes, please.
Sir, hypertension is controlled, sir, or uncontrolled?
Controlled.
Controlled. So in this scenario, sir, patient is 50 years old with the hypertension controlled and diabetic control. Means ASA2 patient. Then we will be considering the history examination and investigation. We will approach from there.
Okay. So what are you expecting?
So regarding laparoscopy,
regarding this patient?
patient is having laparoscopic cholecystectomy. We will be watching all the labs, LFTs are rearranged or not, PTINR, how much liver is
Let me
compensating.
let me just correct you. You yourself said that you will start from history and then examination and then investigation, and now you are telling me directly the investigation. So shouldn't be there something which is related to history, related to examination before jumping into investigation? Okay, actually I'm just giving you a approach how you should be approaching a patient. Okay, now I will correct you that what you should be looking at, because if even if this data is there with you, okay, the thing which you should be looking at is that, like, what else as a like because whenever we are approaching any patient, there is one patient identity, there is one disease, and there is one surgery. Okay, patient identity, like this is a 50-year-old male. Okay, so yes, I have given you a hint that this patient has good physical activity, but a good physical activity does not 100% rule out any uh, complication. Yes, it's a predictor that there will be less chances as compared to a patient who has angina or anything like that, but still, with reference to the surgery, when the surgical say you will add on the surgical concerns, okay, then there may be some things which can occur unexpectedly. Okay, so you will be just looking at other things. Like, other things means that you will be looking at, for example, I did not tell you, but maybe this patient has a history of smoking. So you will be saying that I will be taking history with reference to the medications the patient is taking. This will be part of history. And the other, like, I'm just telling you the summary of with reference to this case, but usually you should have all the demographic data, his occupation and everything. Okay, personal habits, any family history or things like that. Okay, and anything complications, we did not think about any complication with reference to diabetes mellitus and hypertension, because uh, this patient still can have some problems with reference to diabetes and hypertension. What are these? Those, the microvascular and macrovascular complications. Okay. So your history taking should be focusing on with reference to that, like you will be looking at retina. You will be asking about any problem with the eyesight. This will be, and followed by, if there is any history, then you will go on for fundoscopy. Okay, and then you will correlate with anything like that. Similarly, with reference to kidneys, if I have only given you a data with reference to good physical activity, but the control, even controlled diabetic and hypertensive patient can have nephropathy. So there may be some history of hematuria or infections or things like that, but usually it will be the albuminuria. Okay, or like glucose. Okay, and with reference to, just a second, I request all of you to keep your mic mute. Okay, with reference to ultrasound with cortico medullary differentiation. Okay, so you will have to consider this thing, that if you will, of course, you will do this simple RF, this urine RE, and if there is there, then you can go for further investigation. Okay, so or this should be in your, if this should be in your mind. If it is not in, even in your mind, that this can be there, you can be caught in any exam. So this scenario. Similarly, with reference to like CVA, with reference to like I'm sorry, not CVA, brain. Uh, you can have a history of TIA or CVA. Why? Because both diabetic and hypertension is a risk factor for atherosclerosis. Okay, so diabetic and atherosclerosis. So atherosclerosis can occur in brain with reference to this TIA and CVA, okay? And in the heart, it may have some ischemic changes, ischemia, arrhythmia, okay, palpitation initially, or it can go up to like angina or MI or failure. So your approach should be like that you have to rule out like that, okay? And with reference to peripheral vascular disease. So there may be intermittent claudication or some ischemia, peripheral ischemia. So if you want to rule out, of course, you will ask some questions and you will rule out. If there is something in the history, then you will go to history and examination, then you will go to the relevant investigation. Not all diabetic and hypertensive patient will be needing all these detailed investigations, but it should be in your mind that you might expect these things. Like diabetic patient, of course, in history and examination, according to their control, how they are taking, what medications they are taking, you should be considering the side effects of those medications. So I'm just giving you a hint that if you find any data, how to explore, okay? Because I have a lot of agenda to cover today. So I have discussed each and every system in detail, and you can find it in the YouTube channel, which like I share every now and then. So in the preoperative assessment and preoperative planning, I have told in detail. So today I'm just giving you a hint that how you can proceed uh, for each system like that. Okay, if you like heart, you will do with simple ECG. If you find something in ECG, then you will go for echo. According to the risk factors, you will go, if there is something, then you can go to thallium scan or Doppler, or sorry, stress thallium, or this one, stress echo, angiography, even up to like cardiac intervention, according to the findings, according to the history you find. Yeah, according to the history examination, and then further things will be. But this is the sequence of event you should be knowing, that what finding you will have in the history, which will lead you to have history and examination, which finding you can have, then it will be leading to the further investigations which you need, and then the multidisciplinary team involvement. So like the basic message which I want to tell you, that if you have any patient, you should be knowing how to evaluate. And evaluation does not come directly to the from the investigation. The evaluation comes always from the history, relevant history and examination, and then according to the history examination, investigation. Okay, there is no concept of baseline investigation. There should be, all investigation should have some reason. So that's what actually I have discussed in detail separately, all the investigations and all the history examination, all the system wise. So today I will just bypass from here, and I will go to the further things. Okay. In this case, we don't have a very like special age group, but 55-year-old can have some issues with reference to, if like smoking or anything. If it is older age, then there will be some other issues. If this is male, if you have a female in 55 years age, only one thing you can expect, other than all the disease which you have, even only the age will tell you that this patient can have this menopausal postmenopausal syndrome. Okay, so patient might be taking steroids. So this thing will be, it should be in your consideration, because any patient in steroid, hypercoagulable state, need of anything like that. So you should be thinking according to the, as I told you, that one is the patient identity. Patient identity, it may be a female or a male. There will be some things related to only gender. Like if you have a female patient, there will be, if a young patient, you have to rule out pregnancy. Okay. If she is an old age, as I told you, or middle age, you have to rule out postmenopausal things. Then any female patient is at more risk of PONV. Okay. So now you can expand your mind, that you have a female patient. So what things you can expect in a female and in a male. Okay. So there will be certain things which you should be thinking like that. Okay. And of course, the disease which the patient has will have all the concerns and all the history. But remember, the word evaluation is the proper word which you should be uh, using. And then it is followed by history, examination, and investigation. Okay. So this is how you should be approaching. So my message to all the residents, who wherever you are, whatever you are doing, make your approach like that. What's like, for example, if you have any disease, you should be evaluating like that. And any surgery, of course, cholecystectomy is is a different sort of surgery. But if you find a number of surgery, you should be knowing what is the reason for that surgery, why that surgery is being done, and what is the extent of that disease for that the surgery is being the surgical things which are associated with that. Like for example, I'm giving you an example. If you have a patient with appendix, even that appendix patient can have vomiting, and vomiting can lead to electrolyte imbalance. Okay. The patient will have full stomach, so these things will be the concerns. How much prolonged history it is there, that will be some very important for you to think. See, maybe there is a appendicular mass, maybe there is rupture. So with the history, you have to think. Of course, this is surgical aspect, but you, whenever a surgeon tells you that I'm going to do this case, maybe he is not interested to tell you these things, but you should ask how much is the history, what is anything special, because every patient will be different. And categorization is very important for you to categorize how severe is the condition. Okay. So the scenario which I have told you, laparoscopic cholecystectomy, of course the concerns related to only laparoscopic surgery. It is common with any laparoscopic surgery, like trocar insertion. Okay. Like creation of pneumoperitoneum. Okay. And pneumoperitoneum, at that time when they are introducing the air, it can cause embolism. Okay. And once it is pneumoperitoneum is created, then there will be multisystemic involvement with reference to respiratory system, cardiovascular system, renal system. Okay. And and your anesthesia equipment related things, like you might have like dislodgement of tube in the bronchus, airway pressure, things like that. Okay. So and all last thing will be with reference to CO2 absorption and its effect on the systems. So whatever surgery you are doing, you should be considering all these things. uh, I'm giving example of lab chole. You should be finding in every case, you should be seeing. I will show you data in which will help you in identifying in every surgery what you should be looking at. Okay. So these things will be related to the surgery. And in the surgery also, yes. Okay. So with reference to urgency, okay, with reference to any critical, I will just show you. Just give me a second, please. Sorry for the delay. Mm, Okay, with reference to surgery, you should be seeing what is the urgency, what are the surgical risk, bleeding risk, any position. Like in this patient, Some surgery can be in prone position, some surgery can be in lateral position. So when they are telling you any surgery, you think about these things. Okay, that what, because your anesthesia plan will be accordingly. You should, if you forget that this surgery occurs in a specific position, or anything is involved in that surgery, or any critical step like creation of pneumoperitoneum is a critical step in this laparoscopic surgery. Maybe if you are dealing with any other surgery, you will have some critical step. Okay, so you should be knowing, and you should be revising when you are planning, and this is the part of your training. As well as when you are training someone, you should be asking what are the concerns in with reference to that surgery. Okay, so these points which I have just chalked out, it can help you. Okay, so there will maybe some requirement of some logistics. You should be, it may be asking what anesthesia technician should prepare, like anything you should be needing for that surgery, any preparation with reference to that overall case, because of the disease, because of the patient identity. Like for example, if a patient is a neonate or a pediatric patient, you should be focused more on maintaining the temperature of the room. You should be using appropriate size equipment. You should be using small size syringes. You should be using microburette. You should be using like things like that. Okay, so if you don't know these things, you will not be able to plan. And if you know these things, for every surgery you just think like that. For any procedure or any specific age group or any patient, you, it will be in your mind that these are the common things. So this will help you a lot when you are preparing any case. Okay, so similarly with reference to disease, as I explained to you, these are the same things which I have mentioned with reference to, for example, hypertension, what sort of disease, diabetes, like pathology, what happens, this should be in your mind. And diagnosis of the disease, evaluation of the system involved, estimating the severity of the disease, it will be. And you will just think about, because whatever you are doing, you should be thinking about airway. You should be thinking what, because all medications will be affecting the heart cardiovascular system. All your anesthesia will be affecting cardiovascular system. So you should be knowing all the medications has to be metabolized by liver or and excreted by the kidneys or things like that. So you should be knowing about it. Okay, so this is just an idea. And whenever you are evaluating any case, you should be thinking what are the cardiac risk in that case, what are the pulmonary risk, what are the renal risk. Like diabetic patient should be thinking that this patient can have some renal impairment, borderline. And if you are giving, for example, this surgery in which there is massive fluid shift, and there are chances of hypovolemia, hypotension prolonged, and you are using a lot of NSAIDs, so that will pose a patient for post-operative renal failure or renal impairment. So you will think, you will be using the technique in which you will be like thinking about these things. So I'm just giving you a hint. Pulmonary risk, for example, a patient smoker is a pulmonary risk. Upper abdominal surgery is a pulmonary risk. So you should be thinking in that way, because in exams, most probably they will not ask you, tell me renal risk. They will be telling you a surgery, and you have to think, is there any cardiac risk? Is there any renal risk? Is there any pulmonary risk? Is there an aspiration risk? Like any surgery in which vagus nerve is involved, or in which balance system is involved, it is at risk of PONV. Okay, any patients with having any problem with reference to either mask ventilation, or creating any problem with the laryngoscopy, or placement of the endotracheal tube is a risk. Okay, so with reference to airway management, so you should be thinking about any special monitoring needed in addition to standard 1, standard 2 monitoring. You should be thinking about it, is this patient is at risk of more bleeding. So you will be doing all the manipulations, or all the like things which are needed for that thing. Okay, so this document I have shared a number of times. You can have a look. Okay, uh, so every patient, you, if you plan like that, then it becomes very easy for you to target. Okay, so this is with I have just I will share this document. This is with reference to history and examination, how you can evaluate your patient with reference to all the systems. Okay, so now I will go to the next step, which I just want to discuss right now. That the same patient which you were doing after intubation and everything, you have a you are using a pressure control ventilation with a pressure limit of 15 and respiratory, like this is the pressure control limit. Okay, and then you have a respiratory rate of 12. Okay, and you have put a PEEP of, for example, 5 respiratory rate. Okay, and now when you look at the vitals, the blood pressure, yeah, is 130 by 80, heart rate is 86. Okay, oxygen saturation is 96%, and the tidal volume which is coming is actually only the weight of the patient is 80 kg. Okay, once they have done the pneumoperitoneum, the tidal volume has started decreasing. Still, saturation, you can say, okay, I make it 98. These things. Like, what would you like to do? Tidal volume is only 250. What would you like to do? First of all, one different thing which I have told you, that usually in our setup, or majority of people, actually they are doing volume control. Okay, so if I give you the same example of volume control, it will be like that, 500, and now the pressure is going high. Okay, it is touching 30. What you should do at that time? And now end tidal CO2, you see, it is like 45. So what should be your action?
The tidal volume is decreasing.
Like, I have given you both the scenarios. If you are using pressure control ventilation, tidal volume is coming low. And if you are using volume control, the airway pressure, peak inspiratory pressure has gone up. Okay, the end tidal CO2 is going up. So how you should approach this patient? What you should do at this time?
Sir, we will CO2 is increasing. We will increase the rate, respiratory rate.
Okay, what will happen then?
CO2 will come down, and at the same time, if tidal volume is not patient is not
Would
making
you
tidal
like
volume.
to would you like to see something before proceeding? What is the drill? How you should approach this case at this scenario? You will directly increase the rate only, or would you like to see something else? This is laparoscopic
Yes, sir. We
cholecystectomy which is going
will
on.
see, sir, bilateral chest
Bilateral.
auscultation. If
Okay, because you are expecting that maybe the tube is gone on one side. That's why tidal is going low, because they have done the pneumoperitoneum. Okay, so you can or you should confirm this thing before proceeding to one thing. Okay, then another thing, just tell me one thing. If, for example, if we talk about pressure control, so like the total pressure coming is, with the PEEP is coming 20. Okay, and tidal volume is coming 250, for example, and respiratory rate is 12. What is the better way? Should you increase the airway pressure, or should you increase the respiratory rate? You got my question?
so, we will, sir, increase the pressure, sir.
Yes, because 20 is not too much. So you can go a little higher up in the pressure first. Why? I will just, this is a very simple thing, but I sometimes ask my residents around me, and unfortunately they are not able to. So that's why I want to highlight. This is a very simple thing, but you sometimes we forget. I will just give you example. If you have a tidal volume of 500 with respiratory rate of 10, the minute ventilation is 5 liters. Okay, and out of that, roughly, for example, if you just make 150 ml as dead space, the minute So tidal volume is 350 multiplied by 10. The alveolar ventilation is 3.5 liter. Okay, this is one scenario. Now you have a patient with a tidal volume 250 and the rate is 220, for example. So the minute ventilation is the same. But do you think, are you good? The answer is no, because the same 150 ml dead space you will minus. So the effective tidal volume will remain only 100. Okay. So though the minute ventilation is the same, there is significant difference in the alveolar ventilation. So here it is 2 liters and here it is 3.5 liters. So the message for all of you is that try to increase the pressure to the allowable limits before going to increase the rate. Because if you are increasing the rate, actually, practically it is not helping you in that way as compared to increasing the tidal volume. Tidal volume is more important to the allowable limit than, I hope you understand. Got it? Whenever we give a tidal volume, there is a component of tidal volume, there is dead space. Okay, so that's what I was just trying to tell, that the minute ventilation is the same, 5 liter, but alveolar ventilation here is 3.5 liter. And if you only increase the rate but not the tidal, so there is effect on the alveolar ventilation. So that's what I wanted to tell you. So this is one important thing. Okay. So, because whenever you face any problem, you have to go to the basic. Okay, you should be looking at the airway pressure. You should be looking at the bilateral ventilation. Okay, because tube may be touching the carina or on one side. So this thing should be in your mind before going further. And then if you are using, for example, end tidal CO2 is 45, not in every machine or every setup you will have this, but you should be looking at and if you have the agent analyzer, you should be looking at the FiO CO2. Okay, because one of the reason of increasing end tidal CO2 may be that the soda lime is exhausted and there is 5, for example, inspiratory CO2. So it will also affecting this one. Okay. Then again, you will be looking at the blood pressure and the heart rate, and you will be comparing it with the baseline. Because if they are affecting, you should be anticipating. Because I'm just trying to give you a like a mimic a real time scenario. Okay. So this you should be considering when you are dealing with such scenarios. Okay. Suddenly, now you have an ECG and now you see that the patient is having PVCs. Okay. The same patient, when we started, the blood pressure is fine. Blood pressure is the same 130 by 80. The heart rate is around 80, 85, 86. Okay. Saturation is 100%. Okay. And now you see that there are some PVCs coming. What you should do?
It might be due to tube touching the carina. It may be due to
Okay.
this
So again, the drill will be the same. Drill will be the
bilateral
same.
check.
Okay. Then if the hemodynamics are fine, that maybe it's a reassurance that things are good. But you will be looking at the number of PVCs, that how frequent PVCs are coming. Okay. Because diabetic patient and hypertensive patient can have ischemia. Okay. So you will be touching the patient if there is any other clinical sign symptoms which can give you a hint that there is some ischemia going on. Okay. Then you can like if you are not able to control, like what else you can do, you can make 100% oxygen. Okay. Then what is the common thing which you do? What else you should be ruling out other than before going to any pharmacological management? What else you can do? You should be considering about the analgesia. Okay, that if your analgesia is good, then again CO2 sympathetic stimulation can tell you maybe the heart rate is fine, but maybe the initial heart rate was 60, for example, because of beta blocker patient is taking, but now suddenly the heart rate has become 86. So this is in significant increase from the baseline. Okay, so you will be comparing with the baseline. Maybe the blood pressure was 100 by 60 after settling down, and now the blood pressure is 130 by 80. So like you should be thinking in that way. Okay, just a second. Okay, so if you rule out all these simple things, then what next you can do? You can give some lidocaine. Okay, you can just try with simple like 1 to 2 milligram bolus of lidocaine. Okay, if it is working, okay, fine. Otherwise, then you can go for the next step. You can do some ABGs. So ABGs you will find some, maybe there is some electrolyte imbalance, some potassium problem, calcium. Okay, so then you can go further. If anything correctable, you will do it. If still it's going and it's causing hemodynamic instability, you can like you can have like you can stop the surgeon, whatever play step of the surgery it is, and then you can think something else. Okay, you can send a sample for like if you are thinking on the grounds of myocardial ischemia, you can try to finish the surgery at the earliest possible time, or you can try to have a 12, of course in this scenario 12 lead ECG will be difficult, but you can have a sample for cardiac enzymes. Okay, you can have sample for cardiac enzymes and then 12 lead ECG, or even in the ECG which you are using, you can have some specific leads which can tell you some more specific signs of ischemia or something like that. Okay, so that's how like you can proceed one by one. Okay, in ABGs also you can get some blood sugar. Okay, so this is how, like it's a very simple case or simple thing, but that's should be your approach whenever you have any problem like that. Your approach should be systematic. Your approach should be like you will be thinking about some anesthetic factor, surgical factor, patient factor. Then you will be going to the simple maneuvers. Then if they are failing, then you will go to the next step. So same drill you can do with anything. If you have, for example, suddenly in the same scenario, now what happens? The blood pressure suddenly became 180 by 110. Okay, and heart rate is also becoming 96. What will you do?
But there may be, sir, CO2 absorption, or there may be CO2 on the rising, end tidal is rising. We will
Okay,
rule out that. We will increase
okay.
the rate,
End
and we
tidal
will
is end tidal is 40.
end tidal is 40. It is little bit increased. Then we may increase the
You
respiratory
can come
rate.
down. You can increase the minute. You can say you can increase the minute ventilation. Okay,
Okay.
this is a better answer than only saying increase the rate. I have just mentioned you a while ago. Okay, then minute ventilation. Then what else you can do? What you should doing here? You should be again analgesia. Okay, then what should be the next step? You have given adequate analgesia, you increase the CO2 comes to 35. Okay, the blood pressure is still 185 by 105. What should be the next step?
So we will start antihypertensive drug.
Wrong, wrong. Would you like to again? It will be dependent on the different setups, but here you will be looking at the MAC. Is your anesthesia is adequate? Are you having adequate 1.5 Mac? Achieve you are getting around that one or no? Okay. If you are having this thing, then you can go. Otherwise, you will try to increase the depth of anesthesia by giving increase in sevoflurane or desflurane or or isoflurane, whatever you are giving. Okay, don't jump to the cardiovascular medications immediately. Anesthesia is your domain, so you can use some propofol.
Yes, sir.
Why not? Why not? Okay, why you are jumping to antihypertensives? Okay, because this is in your domain. First line will be this one. Maybe the things settle down. If they are not settling down, then you can say about beta blockers or whatever you want to say, nitroglycerine or whatever. Okay, but remember one thing. This is the mistake which we do. The first thing is your domain. Your domain is anesthesia. Your domain is your medications. Then go to the other medications. Any counter argument for this thing? Always we should be using our medications first before going to the specific medications. Okay, just a second.
Sir, there may be, sir, patient may be awaking. This might be the possibility. We can
Very
repeat
good.
accurate.
So very good. If you have facility of MAC, because agent analyzer will tell you the MAC, the inspiratory concentration, the expiratory concentration, and what else you can use to see the MAC to the awareness, of course, is BIS. Okay. Then another thing which forgot to tell you. What about muscle
Sir, can
relaxant?
intraoperative hypoglycemia cause PVCs, sir?
Yes, non-specific like you can say it's sort of electrolyte. Okay, so it can cause. It can cause, but it will be least likely as compared to, because hypoglycemia can cause tachycardia. Okay, so whenever there is sympathetic stimulation can present in anything. So hypoglycemia will be indirectly can be related to PVCs. Am I right? Okay, so actually MAC with reference to anesthesia agent, also BIS if you have that one, or O3 monitor if you have, or muscle relaxers. You can have, for example, if you are doing the neuromuscular stimulation, you can see whether there is decrease in the effect of muscle relaxers. Okay, but remember one thing, that in that way you will have some curare cleft coming, or what else? If you don't have neuromuscular stimulation, if you don't have end-tidal CO2, nothing is coming. Can any other sign tell you that the patient has some muscle activity going on? Can one more thing can also tell you?
So increase airway pressures.
Very good. Okay. Increase airway pressures can also tell you that maybe the patient muscle relaxation is not adequate and you need to give the top up dose. Okay. So, and actually practically we do like this. Practically we do like this. You just have to see all other things in. And now another thing, the surgery has gone into more than 2 hours. Okay. And you did not notice the patient now the like you can say that you are expecting some other things. So what other things can occur in this scenario with reference to this increase in blood pressure and heart rate? What can be the reason? Other reason you should be thinking. One of them will be bladder distension. Okay, though this will not be it's not very common, but if it is in old age, or you are not sure whether the patient went to the bathroom before come, or there is no Foley's and you had given some more amount of fluid than usual. Okay, or the duration has gone more than the usual, so you can consider these things as well. Okay, so like I'm just giving you an approach how to target any problem. Okay, same patient, same patient. Now the blood pressure, I'm sorry. Okay, now the blood pressure has suddenly become 70/40. What will you do? The heart rate is the same, or okay, 80. Heart rate is also less. What can be the reasons?
may be due to, sir, hypovolemia. It may be due to we have increased the MAC, due to which blood pressure has decreased. These might be the possibilities.
Okay, hypovolemia also, but again, always try to look at the anesthesia cause first, and then go to the other. Because there may be so many reasons. You were using a medication which has significant effect on the blood pressure. The patient is hypovolemic. Okay, Uh, patient has blood loss. Okay, so what will you do in this scenario? What should be your approach?
So initially, we will give, sir, vasopressors to increase the
Initially
blood pressure.
vasopressor. Initially vasopressor, but usually if the MAC is already 1.5, for example, so immediately, because even you don't have like, again, I will tell you something, that you should not jump to the medications so quickly. Okay, or even if you are giving the medication, try to reduce the MAC. This again, in the allowable limits. Okay, if you think, if you see that you can say that I will just try to reduce the MAC, I will give some fluid. Okay, and in this scenario specifically, is there anything related to the abdominal pressure? Okay, so abdominal pressure is also to be looked at. This answer is actually, this point I forgot to mention. In the other points which we were discussing, it can come over there as well. Okay, with reference to decreased tidal volume or increase in CO2, all in this also should be considered. But here also, that if the pressure is too much, you can tell that you need to reduce the pressure, because maybe the hypovolemia is because of pneumoperitoneum. There is decrease in uh, venous return, leading to decrease in blood pressure. Okay, so this, then you can go for. And if for example, the heart rate is 70 and the blood pressure is 70/40, which medication will be a better choice? Baba, Baba, Baba. Yes.
Eph- Ephedrine.
Yes, ephedrine. Okay, because heart rate is also low, blood pressure is also low. If you will give phenylephrine, then blood pressure, heart rate can further go down. So, like in this scenario, ephedrine will be a better choice. If a heart rate was 110, for example, then at that time phenylephrine will be a better choice. Okay, so you will be approaching, then you can tell anything, of course, but whenever you are dealing any situation, your approach should be systematic. If you are not in a systematic approach, then you can falter. Then another thing also, maybe this is not related, but maybe, for example, you should be looking at SpO2, you should be looking at airway pressure here as well. Why? Because hypotension with decrease in SpO2 and increase in airway pressure, you should be ruling out any embolism. Okay, like this should, of course, the management is the same. Your management will be, initial management will be the same, but at least you should be thinking in this ground that maybe it is because of some embolism. Of course, if the pattern will tell you, the things will tell you, because not all embolism are alike. If there is no apparent reason you did not find, and but something happened like that, in the differential diagnosis, embolism will also be there. Of course, not if you have only a single reading and you give a small bit of vasopressor or small bit of fluid and things get better. Of course, it will not be like that. But if it is not responding to the normal therapies, you should be ruling out embolism. Okay, so
So we may also think of, sir, pneumothorax.
pneumothorax, yes. Pneumothorax can occur in this scenario with reference to what can be the reasons. Increase in airway pressure, okay, also pneumoperitoneum, and also there may be injury to, for example, the diaphragm. So this can also uh, cause such things. Okay. Any question or any comments up till now?
Sir, in this particular patient, we are, sir, what will be the choice of muscle relaxant
Choice of muscle relaxant.
in laparoscopic cholecystectomy?
Actually, there is no specific choice. Of course, in Pakistan, rocuronium is not frequently available, so we are just left with cisatracurium or atracurium. Okay, so
So
but
I
there
am
is
talking about depolarizing or non-depolarizing among
not
these
dipol.
groups.
Actually, there is no. You are talking about suxamethonium.
Yes, sir.
Suxamethonium is. You can say that there is no compelling indication of suxamethonium. If you ask me practically, I don't. Might have not used it for last 12 years.
Sir, in this patient, if we will be mask ventilating, there may be, sir, inflation of stomach, and there may be
Okay,
difficulty
okay, okay,
in
okay.
suction.
Just a second. Just a second. I will tell you these things. Very important thing. First of all, if you have availability of rocuronium, okay, you can always have modified rapid sequence induction in which you don't need to ventilate for some time. Number one. Number two, make it a habit. If you have a ventilator in which pressure control ventilation mode is there, okay. If you are trying to ventilate after giving muscle relaxant, try to do it with pressure control ventilation. That's why actually practically I have stopped using volume control, because I will ask this question: is there any indication in which pressure control ventilation should not be used? In my concept, there is no compelling indication. If you are getting the good result of minute ventilation, a relatively acceptable tidal volume, the pressure control ventilation is the choice of ventilation. The problem is that you cannot sleep or you cannot leave the room putting the patient on pressure control ventilation, because if there will be any change, patient gets awake, tube is kinked, there is leak in the circuit, anything like that, patient will not have the minute ventilation will be decreased. So you should have a constant eye on the patient with reference to that thing. On also, if you want to avoid gastric insufflation, as you mentioned in your question, that you should maintain the pressure less than 15. Okay. So if you put, like, just imagine after giving induction medications and everything, you have hold the mask with a good technique. Okay. And if you are expecting difficulty, you have put an airway, and now you are getting a very good ventilation with airway pressures of 15. There is least likely that you will have gastric insufflation. Especially a practical point: what is ramp position? What is ramp position? Do you know about ramp position?
Sir, rapid airway management position, sir.
Okay. So the target is that you bring the external auditory meatus at the level of at the angle of sternomental angle, okay, or angle of Louis, sternomental angle. So if you are in a habit, this is a practical tip I am giving you. If you make a habit of making intubation in whatever patients you can in a position nearer to RAM position, or increasing the head side up, believe me, your ventilation will become much easier than when you are doing with the patients lying flat on the bed. So this is what I have learned in my career, that like, if you are, because unfortunately we don't try to do new things, so we are in a same mode. We don't want to change our practice. Okay. So what how I learned to do this: when I had to do a lot of bariatric surgery. Okay, so in bariatric surgery we need to make a position like that in which you have to help your intubation. Then I came to know, then I started thinking, why not try in all patients? So actually I try to do not in all on patient it's needed actually. Okay, but actually if you are doing it, it's always helping you in intubation, it's always helping you in mask ventilation. Okay, so if you want to check it out that you have done a very good airway management, if you start the surgery and surgeon doesn't ask you to put NG tube, this is a sort of uh, satisfaction for you that you does not insufflate the stomach. Okay, so I hope I answered your question. Okay, so muscle relaxant of choice in this scenario is not specific. Suxamethonium is actually, there are so many side effects that unless it is strongly indicated, of course, this word are difficult to understand in scenario of Pakistan where we don't have rocuronium everywhere available. Number one, number two, or places where you are doing a lot of emergency surgeries. Not everyone will have this experience of using non-depolarizing muscle relaxants in emergency cases. And of course, this is, you can say, matter of experience and skill. Not everyone can do this. Okay. But with rocuronium, if you are using a very high dose, you are doing the pre-oxygenation, actually you can get the intubating conditions very quickly before the patient desaturate. Okay, so actually it will help you out with reference to rapid sequence detection. But if you are using even cis atracurium, I'm telling you the practical aspect. Please don't you cannot answer this question in the exam. But if you are if you even if you are using atracurium, okay, and you expect that there is, of course this will be according to your experience, the facilities you have. Okay, you cannot do this technique in every patient, but if you have the facility you can use the priming. Okay, if you have bougie, you have glidoscope, or you have video laryngoscope or things like that, in which you are happy that even if you face a simple intubating problems, you can tackle with them. You have bougie, you have stellite. Okay, so you can try to give even atracurium. Okay, if you do the priming, the effect of atracurium with subsequent dose will be quicker, and you don't need to ventilate for a longer time. Practically, I tell you something, again, not mentioned in the books. I'm telling you my practical or this, you can say, some experience you get used to by your experience. Your experience is also a research, or all your experience is also a book in yourself. But because we don't have the we are not in that part of world where we are doing a lot of research. But in my opinion, if you do this technique, priming, or even sometime if I'm happy that there is no problem with the ventilation, actually I give the whole of the dose even before giving muscle relaxant with reference to atracurium. Because what has happened, rocuronium injection is painful. So rocuronium injection is very difficult to be given before loss of consciousness. So priming is very difficult with rocuronium, number one. Number two, atracurium already will take some time for its effect. So still you can ask the patient to have deep breathing, pre-oxygenation. At the same time, you are asking the patient to breathe, and you can give atracurium to start with before giving all other medications. And then you gradually, so you will minimize the time for ventilation. So the chances, and you have already make RAM position. So you are minimizing the chances of difficulty in airway management, difficulty. And another thing I tell you, that aspiration sometimes occur. One of the biggest factor is increased airway pressure while you are ventilating the patient. Number one. Number two, when you are making RAM position, another advantage is that the whatever gastric pressure is being developed, it needs a lot of pressure to be developed in the stomach for the regurgitation to occur, because you have make it against gravity. So the whatever contents have to come against the gravity up. I hope you understand. Because if you have make the head side a little up, so actually the angle become like that the gastric pressure need to be very high up to reach the for the like regurgitation to occur. So actually This is again, this is a practical tip I'm telling you, that if you are making in wrap position with pressure control ventilation, because if you are bagging with the hand, either you are giving very high pressures, either you are hypoventilating or hyper. Majority of cases, you are giving a lot of higher pressure than required, and your one hand is fixed. So your hand technique, mask holding technique is not good. So I don't remember when I did ventilate the patient with the mask, with the bag. I always put all my patients in the ventilator. Okay, put on pressure control, and then things are in your hand. You can adjust the things accordingly. If needed, you can put the airway. If needed, you can like have a better jaw thrust, chin lift. Okay. So again, this is a practical experience I have shared with you. Okay,
Sir,
Pratik?
with how much pressure do you start, sir, like ventilating when you're starting? What's
15,
the pressure you keep?
15, 15. Okay, 15. And another thing, default machines, even good machines, they always have PEEP. So my question is that once you are starting the ventilation, should you open the PEEP? Yes or no? Please.
I think, sir, we should start the open the peeps.
No. When you are doing the mass ventilation, it's useless. You are just increasing the airway pressure for nothing. Okay. So start, you close it, make sure that your peak airway pressures are not crossing 15. Okay. And then once you have achieved your goals, then you can adjust the settings. When the tube is inside, you can do whatever you want. But at that time, because PEEP takes some breaths to be developed. PEEP is not in single breath. You have, because the default machines are like that. So we are bound to use like that. Okay. But whenever I'm standing on the head side, I always do like that, because now I'm at part of at a stage of my career that always I have like a number of times I have junior resident with me who is doing this, or even your registrar is doing with you. So things become different. But if you want, this is a teaching stuff. Please always teach your residents to hold the mask in a proper way. Number one. Number two, they are in habit of putting the airway immediately. I stop them. Airway is the last resort, not the first resort. You should hold the mask in a proper way. You should do the jaw thrust, because airway is an irritant. Airway is an irritant. Okay. So it's not a very nice thing. Yes, you have given muscle relax and everything, but still it's inside and it's irritating, and it's increasing the sympathetic activity. So for no good reason, and actually you will not develop your skill. If you are in habit of putting airway all the time, you will have a patient in which you are not able to put the airway. What will you do? Your muscle tone, your hands are not developed to hold the mask, and then you will have problem. Okay. So make a habit of holding the mask in a way. Actually, I say that if you are holding the mask and if you don't have pain in your forearm, it means you are not holding in the correct way. Even if with the experience, even then you should have some tremors in your hands. It means if your muscles are not being used, you are not holding tight in a nice way. Okay. Of course, there will be different category, but usually you need to hold the mask a little in a better way, so that you have, or at least train your residents, or train yourself in a way that you are able to, because maybe you are the only one. If you are only one and you need to hold the mask with two hands, who will ventilate? Okay, so if you are not in habit of using your hands to ventilate the patient, you can have problem. Okay, so this is what I wanted to tell you. Already we have consumed more than 1 hour, so I just started after some time. Even before that, I used to have frequent sessions, but unfortunately, because of lack of interest of majority of the residents, unfortunately, I stopped. But like I am available 24/7 to any one of you, whosoever wants anything from me. You all are welcome. Yes, Pradeep?
Sir, is there any method or procedure to check intragastric volume? Is gas is inflated due to mass ventilation before
Ultrasound?
starting surgery?
Ultrasound?
So routinely
We are not trained in it,
we
but it is the answer. Okay. We have to learn.
So I'm
Ultra,
confused, sir, because in
you,
if surgery is started, there will be difficult position. If surgeon is asking for NG, then in that position, I faced very much difficulty in putting
yes.
NG.
Actually, I tell you something. For that, you have asked a very good question. But I will suggest all the junior residents to learn ultrasound, because a number of things which I should have learned when I was a resident, unfortunately, we don't have that facilities. Number one. Number two, in Saudi Arabia, anesthesia and ICU is separate. So we are not working in ICU. And for this is another unfortunate thing for us being a trained intensivist. Okay. So future is focus, point of care ultrasound. So you should be, you have asked a good question. So I will just highlight some of the utilities of ultrasound before we just finish that as you mentioned, stomach, residual stomach volume. Okay. Confirmation of your lines and tubes like endotracheal tube, NG tube. You can confirm the position. Some prediction of pneumothorax, pulmonary edema, whether your lungs are wet or dry. Then vena cable IVC compressibility. Okay. IVC compressibility, like for example, in that scenario, that if you want to identify whether your patient needs inotrope, vasopressor, or your patient needs fluid, you can do this with IVC compressibility. Then another very important very important utility of ultrasound is with reference to spine. Spine ultrasound, you have to identify three things. What is the level, like which level, whether you are L3, L4 or L2, L3, number one. Number two, where is midline? Okay. And how much is distance from the skin to the space? What is the level? Where is midline? And even you can identify the angle. Okay. So then placement of CVP, arterial line, okay, even peripheral PIC line, peripheral lines. Okay. So ultrasound is future. So the word for it is focus, point of care ultrasound. And this is with the answers of yes or no. Okay. This is not that you will just say patient is wet or dry. Patient needs fluid, yes or no. Okay. So things like that. Okay, Pardeep? Yes.
Okay, sir. Thank you.
Okay, so I hope you got benefit in some way. Special thanks for my friends from, I think you are from Nigeria. Am I right?
Sir,
Yes, yes, from
hello.
Nigeria.
Okay. Yes, Sumera.
Sir, I want to know how much atricurable we have to give as a primer dose.
Actually,
One
priming
book.
dose, what the book says is 1/10. Okay. But practically, I told you that if I don't find any problem with the ventilation, actually I give early. Okay.
Thank
Even again, this a number of things are the things which are not bookish. I will never ask you to tell to anyone on academic forum, because this is my personal experience. But I'm just telling you, it is possible that you can give a whole of the dose. The effect will be very quick. I've told you I have never used in majority of scenarios, because of course, becoming a consultant, we are not doing the emergency duties. This is one reason maybe.
you.
And in last few years, like last decade, I have not worked much in hospitals where there is emergency care. I was working in specialized hospitals. where I did not need to use it. Then another thing with rocuronium, because at that time I did not tell you this thing. With rock, you need to anesthetize the area with lidocaine, or what I do another technique, because I always use ketamine is my friend. So I give a small dose of ketamine before giving lidocaine, or with the fentanyl before giving rock. After giving these 2 3 medications, actually the effect of rocuronium is decreased. Or another way is that you can dilute rocuronium. So you can use this with this technique with rocuronium as well, the priming. Usually the bookish dose is 1/10, but practically I told you that I give a lot. I give because with the rock, even there is a ease that you, whenever you are using rock, if you have Sugamedex, you are safe. There is no problem.
Yes, thank you.
Any other comment or any other thing? Because I tell you something, a number of things, our practical experience are always debatable. I never say that whatever technique I'm using is the perfect one. Okay, there is always room of improvement, and always, of course, don't try the things which are dangerous unless you have fair experience. Okay, because if you have any doubt about the airway, don't do these things, because luckily I'm working in place where we always have the availability of sugammadex. Okay, with atracurium, if you give atracurium and you are not able to intubate, this will be a big problem. So this is the
Yes,
only, you should be knowing before
very
doing these things. Okay.
yes.
Okay, so thanks a lot all of you to honor me by joining, and we will come back with some other topic. All the people who are working in any capacity, I will suggest to you, if you want to be in touch with the studies, please start spreading the knowledge, start teaching. The best way to learn is to teach. If you don't speak out, you will never be able to keep the knowledge with you. Sorry. Okay, before we finish, any more question? Okay, so thanks a lot, all of you. We
Thank
will.
you, thank you, thank you.
Okay,
Thank you, sir.
so
Thank you.
yeah,
Thanks.
I just want to tell you that my YouTube channel is non-monetized, and I have no financial conflict of interest, because if you tell someone to use something and you, there is something in mind, you will be, but actually I have discussed all these. This is my channel, you can see it. And the thing is that the advantage that I don't uh, like, I'm not doing it with reference to making very beautiful slides, because it is difficult. Okay, but I have done all the discussions like I did today. So if you listen to it, you will get a lot of benefit, and all of you are welcome. If you have any doubt about anything, you can share me the link of that, and I can explain to you. Okay, there are some things which are not related to like medical science. There are some other religious things which is are the channel, but majority discussions are in English, and there is a playlist separate with the English discussions. Okay, and some of the discussion is in my like our native language, Urdu, but majority are in the English, because I am a big advocate of counseling the people for their career. I have done a lot of sessions or career counseling, and you can find here. Okay, so anyone if want to have any question about career progression at any stage of career you are, you can ask me anything anytime. Okay, I have dedicated myself for serving my specialty, so I don't mind. You can drop a message to on WhatsApp to me, and I will be very happy to answer. Okay, so because when I remember, I will just tell you something. The best way to learn is to teach. And as soon as I started few years ago teaching verbally, orally, actually I learned a lot. Okay, before that, and this WhatsApp channel is there. Sorry, this WhatsApp groups are there since 2012. But like I started teaching only maybe 3 or 4 years ago. So I have it has helped me a lot. So I will suggest to you, it is caring about others is is the intention you should have, but the biggest beneficiary will be you yourself. Okay. So, and in our life, where we have so much selfishness. So if you think about others, believe me, you will get a lot in your life. It will turn back to you. Okay. So that's what I can advise to all of you. Okay. So thank you very much. And last thing, for especially people from Pakistan, please don't worry about the exams. Exams you will pass easily if you have good concepts. If you will just try to jump to pass just to get the queen, what is the answer to the question? What is the answer to the question? Believe me, you will pass the exam one day. But just imagine, would you like your mother, your father, your dear one, your anyone on a lighter note, anyone other than mother-in-law or sister-in-law for women. Other than that, yes, maybe our sisters will not be interested in giving very good care to their mother-in-law or sister-in-law. But other than that, would you like any one of your dear one to be anesthetized by by a person who does not have the clear concept? You will never. Okay. So my suggestion to you, please, we don't have how much life we have. Whatever life we have, we should try to do the best. Again, I repeat, exams is nothing. If you will have good concept, you will pass the exam. But you should be a good doctor, because we are dealing with human lives. We are dealing with someone's father, someone's mother, someone's sister. So if you don't have the clear concept, even if you pass the exam, believe me, you will be more dangerous than failing till the time you have the correct concept. Okay. So don't think about only passing the exam. Okay. Yes, treat patient as you think you are to be treated. Okay, my dear. Thanks a lot. And keep encouraging me by asking the question. I don't need anything else than you spread this message to others. Because what I need, Alhamdulillah, I have everything in my life. I just need more people with my syndrome. I want all people around me to be in the syndrome of helping others, trying to think about others, trying to, if you have become a consultant, never forget the time when you were resident and you wanted something to be taught to you. And if you don't get the chance, so you should be thinking about yourself when you were at that time. Okay. Thank you very much. Bye bye. Assalamu alaikum.